Today on this explainer, we're putting on our clinical detective hats to investigate something fascinating and, honestly, potentially life-threatening. We're talking about the failing adrenal gland. We're going to decode the pathophysiology, decipher those tricky physical clues, and map out exactly how to rescue these patients. And as always, we're going to use a lot of graphics to make this complex topic much easier to digest. So here's our roadmap for today. First, we'll look at the failing adrenal gland. Then compare primary versus secondary causes. After that, we're spotting the clinical clues, running through diagnostic testing strategies, and finally tackling management and the dreaded adrenal crisis. All right, let's jump right into part one, the failing adrenal gland. At its core, adrenal insufficiency is exactly what it sounds like. It's a failure of the adrenal glands to produce adequate amounts of adrenocortical hormones. Now, clinically, we categorize this deficit as primary, secondary, or tertiary. The really crucial point here is that this failure can originate at multiple levels of the endocrine axis. And when it does, it sets off this massive cascade of systemic issues that affect nearly every organ in your patient's body. Just take a look at how the HPA axis is regulated here. Notice how a lack of cortisol from a damaged adrenal cortex literally rips away that negative feedback loop to the hypothalamus and pituitary. Because of this, the pituitary tries to compensate by frantically ramping up POMC production. And what happens? Well, both ACTH and melanocyte-stimulating hormone, or MSH, just skyrocket in primary disease. Keep that MSH elevation tucked away in your mind, because it's going to give us a massive physical clue a little later on. Now let's see how this builds our understanding of another critical hormone, aldosterone. Normally, when it acts on the renal tubular epithelial cells, it upregulates transport channels to promote sodium and water retention, all while forcing potassium out. But when this process completely crashes in primary adrenal failure, your patient develops severe hypotonic hyponatremia, really dangerous hyperkalemia, and profound volume contraction. Which brings us to part two, primary versus secondary causes. Okay, I want to drop a huge clinical pearl right here for you. Despite how much time we spend talking about Addison's disease, the classic primary form, the secondary form is actually what you're going to encounter most frequently. And here's the kicker. Secondary insufficiency is very often caused by the withdrawal of suppressive glucocorticoid therapy. So this is absolutely a crucial iatrogenic condition you need to be watching out for. Now, looking at this breakdown, notice how clearly these features compartmentalize the biochemical differences. Both primary Addison's disease and secondary hypopituitarism share that glucocorticoid loss. That means both sets of patients are going to experience weight loss, fatigue, and hypoglycemia. But look closely at the mineralocorticoid column. That severe mineralocorticoid insufficiency, the kind leading to shock and hyperkalemia, that is entirely unique to primary disease. Let me highlight exactly why that is. In secondary adrenal insufficiency, aldosterone synthesis is not affected. This is a massive distinction. Because aldosterone production is controlled primarily by the Uras system, specifically renin, angiotensin II, not by pituitary ACTH, secondary insufficiency actually spares your patient from that severe volume contraction and hyperkalemia we just talked about. Moving on to part three, spotting the clinical clues. Here is a quick hit you must always remember. Most cases are actually subclinical. They often only become apparent during periods of intense physiological stress. Think major surgery, physical trauma, or a severe infection, times when the body's demand for cortisol suddenly spikes. You really have to maintain a high index of suspicion here, because a patient's chronic, unexplained fatigue, nausea, or weight loss might literally be a ticking time bomb, just waiting for a stressor to set it off. Just take a look at these powerful clinical clues. Look really closely at the profound bronze-toned hyperpigmentation on the face and that dark, almost black pigmentation on the buccal mucosa and tongue. This startling physical clue is a direct result of that elevated MSH we saw earlier in the HPA axis diagram. Since the failing adrenal gland isn't making cortisol, that uninhibited pituitary is pumping out massive amounts of POMC, which then cleaves into ACTH and MSH. It's literally darkening the patient's skin and mucous membranes. Okay, let's talk testing in part four, diagnostic testing strategies. Never, ever forget this golden rule of timing when you're dealing with endocrine emergencies. If your patient is in acute circulatory shock and showing signs of an acute adrenal crisis, you treat them immediately. You push those life-saving glucocorticoids without waiting around for lab confirmation. Conversely, if your patient presents with chronic, stable symptoms, well, then you have the time to perform your investigations before pulling the trigger on treatment. So if you do have the luxury of time, a basic metabolic panel is going to reveal a highly characteristic profile. You're looking for the classic primary triad: low sodium, high potassium, and a normal anion gap metabolic acidosis. This is entirely driven by that lack of aldosterone. Add in hypoglycemia, thanks to the loss of cortisol's gluconeogenic effects, and the biochemical picture of primary failure is totally complete. To truly lock down this diagnosis, we run an ACTH stimulation test. It's elegantly simple, really. First, you draw a baseline blood sample at 0 minutes to check resting cortisol and ACTH. Next, inject 250 micrograms of synthetic ACTH intramuscularly. Finally, you draw another blood sample at 30 minutes. A normal, healthy adrenal gland is going to respond by pumping out cortisol to levels greater than 500 nanomoles per liter. If that cortisol doesn't rise, boom, you've confirmed adrenal insufficiency. And that brings us to our final act, Part 5, Management and Adrenal Crisis. The fundamental rule of endocrine management is that we have to replace exactly what is missing. For glucocorticoids, this means prescribing daily oral hydrocortisone for everyone. Usually that's 15 to 20 milligrams in divided doses to mimic the body's natural diurnal rhythm. But remember that crucial distinction we made earlier. Adding mineralocorticoid replacement, like fludrocortisone, is strictly required only for our primary Addison's patients. Now listen up, because this is a vital warning and probably the most critical takeaway for your clinical practice. Patients absolutely must be educated to stress dose their steroids. When they get sick, they need to increase their glucocorticoid intake to mimic a normal physiological stress response. If they don't do this, their cardiovascular system won't be able to maintain tone, and they risk a rapid, life-threatening collapse. So what exactly triggers this collapse? Well, the most common precipitating factor for an adrenal crisis is actually just a simple gastrointestinal illness. The perioperative period, sudden discontinuation of prescribed steroids, or a bilateral adrenal hemorrhage can also trigger it. And, as the source famously notes, while an Addisonian crisis might be somewhat uncommon in everyday practice, it is incredibly common on your medical exams. So the big question is, will you be able to spot the subtle clues of an impending adrenal crisis before it's too late? By understanding the vital differences between primary and secondary failure, keeping an eye out for that MSH-driven hyperpigmentation, and reminding your patients to stress dose those steroids, you are well on your way. Thank you all so much for watching this explainer. To keep mastering complex topics with us efficiently and visually, make sure to hit that subscribe button for the Mid Medicine channel. See you next time.